It is my pleasure to introduce Noel Eldridge. Noel Eldridge started his career as a contractor at the NASA Life Science Division in 1988, and he went on to work at the National Academies and the American Institute of Biological Sciences. In 2000, he joined the Veterans Health Administration's National Center for Patient Safety as a civil servant. Before retiring from federal employment, Noel also worked at the Agency for Healthcare Research and Quality and the Defense Health Agency. The work by the team he led at AHRQ resulted in numerous papers, including the 2022 publication in JAMA that covered trends in adverse events rates from 2010 to 2019. Noel Eldridge will present on review of national estimates of deaths related to hospital inpatient adverse events and potential for developing a new and better estimate. Noel, the floor is yours.
Okay, thank you, Kevin. Appreciate your invitation and that introduction. I think this is my fourth presentation over the last 10 years or so at one of your meetings with Health Watch USA. Okay, so this is my title. It's a long one. I'm going to do a literature review of estimates over the years regarding the number of adverse events and, more importantly, the number of deaths associated with adverse events, which is a very small subset of the papers that have covered adverse events. And then I'm going to talk a little bit about developing a new and better estimate, which hasn't been done for a long time. So pretty much every paper that you read on the topic of patient safety since 2000 begins with a commentary quoting this paper, the Institute of Medicine, now called the National Academy of Medicine, 2 Errors Human Report, based on 2 studies, one in Colorado and Utah and one in New York, extrapolated out the deaths from adverse events to being something in the neighborhood from 44 to 98,000 deaths in 1 year in the United States. Adverse events being accidents, any kind of mistake that happens in healthcare, from adverse drug events, getting the wrong medicine, getting the wrong dose of a medicine, getting the right medicine at the right dose, but it has an untoward effect either due to an allergy or due to something else, pressure ulcers, falls, infections, mechanical complications from procedures, all kinds of things that can cause people to suffer in healthcare and to sometimes die. So this number was talked about for a long time, for a number of years, and it's always in the beginning of any paper you read that tries to talk about the scope or the breadth and depth of the problem of patient safety in the United States. So then there was quite a bit of pushback on this study, and one of the primary authors of this report, which was a book-length report, the Institute of Medicine study, he pushed back in a JAMA article, Journal of the American Medical Association article, saying that the numbers are not exaggerated and that this is a real, genuine problem in the Journal of the American Medical Association. And that journal published it. They didn't just blow it off. Also, you can see here the part that I circled. IOM called for a broad national effort to include the establishment of a Center for Patient Safety within the Agency for Healthcare Research and Quality. So in 2010, that's where I went to work, at the Center for Quality Improvement and Patient Safety at the Agency for Healthcare Research and Quality. And I was there for 11 years. I wasn't able to develop a new estimate, but it wasn't for lack of trying. Another study that came along 10 years later was from the Department of Health and Human Services Office of Inspector General. So this was a federal report where they looked at adverse events among Medicare beneficiaries, which are about 40% of the people in hospitals, and they're older and sicker than the general patient population in hospitals. And in their study, they looked at 838 patient stays, admissions, and there were 12 deaths that were somewhat related to adverse events. I'm going to go into the details later. There were 12 that were based on adverse events to some extent. So what they did was they extrapolated that out to the whole country. So for 12 out of 838, they extrapolated that up to be about 180,000 deaths a year. This was 1 month in 2008 that they looked at, and they extrapolated that up to 15,000, multiplied it by 12, and came up with 180,000 deaths a year, just in Medicare patients. So that would be a huge number. And these were just hospital inpatients. So now there's two things for context. At this time, approximately 670,000 people a year died as hospital inpatients. So put that number in your head, 670,000 deaths among hospital inpatients. And they're saying 180,000 just in Medicare due to adverse events. And only about 2.5 million were dying overall in the country from all causes and all locations, at home, nursing homes, anywhere else that people might die. So this was a huge number. Of the 12, they mentioned that 4 out of the 12 were clearly not preventable. So that means that everybody did the right thing, but there was some kind of adverse event. So say there was some kind of immediate allergic response or some other kind of outcome that was deadly but not preventable. So this is a very large extrapolation from 838 up to 30 million people in a hospital per year. And it's a very tricky extrapolation. Another paper that came out in 2013 upped the ante even more. This paper, I don't think should have been published, in my opinion. It came up with 440,000 deaths, which was kind of a crazy number, in my opinion. It doesn't really bear scrutiny, and I'll go into that a little bit more. But when you put a number out there, people tend to bite on it. Okay, so this is Dr. Zhao, who was the president of the Institute of Medicine at the time, and he's talking about this problem.
Medical errors can be defined as failure of a planned action to be completed as intended, or the use of a wrong plan to achieve that aim. Now, Ken would tell you the group tried to figure out, based on what available data, how much harm was being done through these errors, and came up with a number 44 to 98,000, and of course, press says 100,000. We know this number is grossly underestimated. I say grossly because subsequent studies more recently shown 400,000. Now, if we started 900,000 15 years ago, we're now at 400. We're moving backwards.
Okay, so that was something that the president of the Institute of Medicine said. Actually, at that conference, I went up to him on the break and I said to him, that study really doesn't hold water, in my opinion, and only 670,000 people are dying every year. So how can 440,000 be dying from adverse events and it's not right in your face every day? He didn't really respond to my question, even though I was there talking to him one-on-one. He just went on to talk about something else. So that was disappointing. But this saga continued. Marty Macri at Johns Hopkins and a colleague Daniels at Johns Hopkins wrote a paper in the British Medical Journal, and they said that adverse events or medical errors were the third leading cause of death. So that is another huge claim. And you can see they calculated pooled incidents that came up to 251,000 plus deaths per year. And then if you look at the other causes of death, he would say that that's now the third leading cause of death. This one also was quoted a lot. Tricky situation. Just by the way, President Trump made him the commissioner of the FDA. So 10 years later, he's running the FDA. But back around the same time, 2016 timeframe, Macri and another colleague wrote a letter to I believe it was the department head of HHS, and this was a public letter. And you could see that he suggested that CDC allow clinicians to list medical error as the cause of death. And if so, it would be the third leading cause of death. And here he also talks about how there's thousands of projects aimed at reducing and preventing harm, but very few are funded, et cetera, et cetera. It's kind of ironic because in this point, he was at Johns Hopkins looking for funding. And then last year, the administration cut the staff at the Agency for Healthcare Research and Quality by over 70% and stated that they plan to eliminate the agency, which is still pending. Despite this year, Congress actually funded it at about 95% of full funding, but there's no staff to actually implement the programs or spend the money. So it's kind of a crazy situation. The agency has over $300 million budgeted, but it's not spending the money to improve quality or safety of healthcare. In any case, this saga kind of continued. There's another study by Kavashojania and others in British Medical Journal. He's another researcher at the University of Toronto. And he went through some of the other historical studies. If you look in these slides, I put the link in for every one of these studies, and I try to use a PubMed link so it will be a good link even in the future. And when he looked at the studies and he picked the ones that he thought were better, he thought about 3.6% of the patients that die in hospitals died from adverse events. So that would be about 25,000. Healthcare Utilization Project, if I remember my acronyms correctly. And they collect data from, I think, about 48 states. I think there's 2 states that don't participate. And they come up with the inpatient mortality in the United States. So you can see here, this is the number of discharges, 35 million discharges, approximately. It actually went down for COVID because they admitted fewer people. But now we're going to look at a different outcome. We're going to look at the number of in-hospital deaths. So the number of in-hospital deaths, as I stated earlier, was around 670,000 in this time frame. This is 671,000. So if anybody doesn't believe that COVID killed a lot of people, it's right here in front of your face. This is just people dying in the hospital. It's just cooking along at 670,000, 690,000, boom, 900,000, over 1 million, and so forth. And this is just in the hospital. This doesn't count nursing homes, dying at home, etc. So in any case, 670,000, 700,000 is the baseline for the country of deaths. And if you look at it as a percentage, discharge percent of in-hospital deaths, it's a very similar chart. And you can see here, before COVID, it was 1.97. It was 2%. So 2% of the people that go into the hospital alive leave dead. So 98% leave alive. 2% die in the hospital. You can see this went up to over 3% during COVID. So keep that in your head for a second. 2%. This is why I'm critical of the James paper. This is John James again, the guy who came up with 400,000. And he wrote it back, a response in BMJ to the previous paper that said it was 25,000. Maybe it was a better estimate than 250,000 or 400,000. He says, my bottom line claim is this. In just over 1%, over 350 million hospitalizations, a preventable adverse event during the hospitalization resulted in a premature death. Well, I just showed you only 2% of the people died in the hospital. So he's basically saying half the people died in the hospital from an adverse event. Or he's saying that they had the adverse event and they were so sickened or harmed that they went to a nursing home and died afterwards or died. But still, 1% would be a huge number. And I don't think it's defensible. You can see my note here. Only about 2% of admissions end in death. So there's been some more studies, and I'm going to give this study here, 2019, said it was the 10th leading cause of death in this ballpark here, around 30,000. And then this one was an interesting one that people don't really talk about very much that I found. It was based on New York City, an underreported contributory cause of death in New York City. And they went through 2,783 deaths in an all-age population compared to 12 deaths in the Medicare study by the IOM. So it's 2,783 deaths, all age, all payer. And they went through all of this information, and I just extrapolated it up to the country. This is a couple of years ago. The population of the US is a little higher, but I think I picked the right year for the US, for the NYC study. In any case, say you extrapolate it up. This extrapolates up to about 96,000 for therapeutic complications, another 12,000 for accidents, 108,000 nationwide. Not a small number, but not 400,000 either. This is another study that I like that was done, surgical adverse events and errors and the relationships to adverse events. This one is a very interesting one by Turrentine et al. In the American Journal of Surgery, if I remember correctly. And in this case, they looked at 5,200 patients that had surgery and had one or more operations during their stay. You know, sometimes patients have multiple operations, especially if the first operation doesn't go as planned. And of those patients, 84 died. This was in one hospital system that they were looking at their own system. So I give them credit for airing their dirty laundry. So the surgical inpatient mortality was 1.6%. So this is interesting to know. This is less than the 2% overall. You might think that surgical patients die at a higher rate than overall patients in the hospital, but it's not true. Surgical patients tend to die at a lower rate than overall patients in the hospital, generally because many surgical patients aren't that sick. People that, were admitted for orthopedic surgery or other kinds of elective surgery that are not for life-threatening conditions, or even cancer surgeries that are early. Having cancer is not going to increase your mortality necessarily, unless it's, advanced. So in any case, of those patients, there was 84 deaths, 53 had errors, and going down the line here, for 26 of those, the reviewers strongly agreed that an error contributed to the death among these 84 deaths. And among the patients that died, they said the patient died of the disease for which they underwent the operation, 68, and the patient did not die of the disease for which they underwent the operation among the 84 deaths. So there's a lot of words there, a lot of numbers to keep straight. And I extrapolated this up to the country. So you can see what these numbers come out here. About 22,000 deaths just in surgical patients dying of something other than disease that they underwent the operation for, something related to an adverse event, related to surgery or the aftermath recovery of after surgery. And I put some little numbers in here just for rules of thumb to kind of make it a little easier to understand rather than these big numbers. Chance of dying after inpatient surgery here was 1 in 62. Chance of dying after inpatient surgery, and the reviewers strongly recommended that an error contributed to the death, 1 in 200 surgeries. Chance that if someone died after surgery, the reviewers strongly agreed that an error contributed to the death, about 1 in 3, about 30%. Chances of the patient died for the disease for which they underwent the operation, 4 out of 5. After surgery, 1 out of 5 deaths were for some reason other than the disease you had that you came in with. So a lot of numbers in these various studies, hard to pull it all together. This is just one more that I found in the last week, updating these slides. This one is kind of a kooky one, in my opinion. This is from the Journal of Public Health, and it was in 2022. I forgot to put the link in here, but these are very strange names. You can Google them and it'll come right up. And they looked at the CDC National Center for Health Statistics, and they found that there were 44,000 deaths, basically, among 18 million people died in the US that they could look at their death certificates. So you can see only 0.25% here. But the funny thing was, to me, this paper is entitled "A Recent Twofold Increase in Medical Adverse Event Deaths Among US Inpatients." So they focused on the deaths increasing rather than the very low estimate. I think the estimate might have been due to some sort of measurement system like ICD codes or something changing, rather than a real difference in the 25 to 19 time frame, because I don't think anybody else saw an increase in that period. Okay, so going back to the government agency that I worked at and some of the work that we did, let's go into this a little bit. So one thing that we were participating in this same time frame with the Center for Medicare and Medicaid Services, CMS, was a program called the Partnership for Patients that was implemented starting in 2011 under Don Berwick, who was the head of CMS for a while, and President Obama had put him in there. And after they passed the Affordable Care Act to try to increase access to health care, they decided, well, we don't want to just increase access to health care. We want to make it better. And one thing that would be better would be if it was safer. So that was part of my job, was to measure the adverse events that were occurring using the tools that we had at the Agency for Healthcare Research and Quality, at CDC, and other federal agencies to the best of our ability. So on this side of the screen, you'll see the rate. HAC stands for hospital-acquired condition, just another euphemism for adverse event or medical error or mishap. And we could see in the data that we were looking at, we saw 145 HACs per 1,000 discharges go down to 121 per thousand in this period, 2010 to 2014. And then we changed our measurement system a little bit, and line 2014 at 99 per thousand. So this 121 and 99 were measured two different ways. And then we saw the rate go from 99 to 85 per thousand. So we saw pretty consistent reductions in adverse events between 2010 and 2017. And we also estimated the deaths prevented associated with these. We didn't really write this up into any publication, but we thought that for about 24 adverse events or HACs reduced, about one fewer death would occur in this period using the system we had there. And then here, we thought about 44 to 1 between reducing adverse events, preventing deaths. And in this period here, 2015, 2016, 2017, we extrapolated out that about 20,700 fewer deaths occurred than if it would have stayed 99 during this whole period, the fact that it went from 99 to 85. Now, this methodology that we developed was actually used in a speech by President Obama in 2015. Not that he talked about our project in any detail, but he just put out a fact or finding from the study, which was that the Affordable Care Act was a major reason for preventing 50,000 deaths. And that was in his speech. The speechwriters took it from some of the press releases and some of the work that we had done, presentations and so forth. And this was a very interesting thing in my career, because the Washington Post called us up and they said, we want to check your facts. So we explained how we did it and how we figured it out and all our numbers. We were very scrupulous about it. We could have made mistakes. I mean, we could have made bad assumptions, but we were very transparent about where the numbers came from. We wrote it up. We put it on the AHRQ website. And when the reporters checked with other experts that didn't work at AHRQ and didn't work for the government, worked in the private sector and so forth, hospitals, they came back and they gave us what they call the Geppetto check mark, which was saying that it was true, that maybe you could come to a different conclusion, but that there was no shading of facts, no significant omissions, no significant factual errors, no Pinocchios. And this was very rare. I think out of 97 fact checkers, like 3 people or something got the Geppetto check mark. So very, very unusual. And it was very gratifying. So the reason I tell you this is that we really were very scrupulous in what we did. Not that we couldn't have made stupid mistakes, but we didn't intentionally try to distort the facts, as I think some other studies have done. So another thing that we did around this time was we extrapolated out this data to make an estimate ourselves, but we didn't make a big deal out of it because we didn't have a lot of confidence in it. It wasn't the most rigorous analysis, and we didn't think it was worth publication, but we did put it in a blog by the AHRQ director on an obscure website. This website I actually checked yesterday, and it seems to have disappeared over time. So I don't know if this exists anywhere anymore, maybe the Wayback Machine or something. So we estimated that about 170,000 people died from adverse events, and about 44% were preventable, which was around 75,000. I mentioned that we didn't publish that, but we did publish a lot of raw data that didn't go into the deaths, showing all kinds of reductions in adverse events. This was 2005 to 2011. We managed to get this in the New England Journal of Medicine, which was a big deal for us. And around this time, we also funded a study from an outside group at the University of Chicago called NORC. Their task was to estimate the additional inpatient cost and mortality associated with selected hospital-acquired conditions. So we went over these different adverse event types with them, and then they figured out what rate do people that are exposed to this type of event die. So for example, adverse drug events, everybody in the hospital gets drugs. So they have a 2% death rate without an adverse event. If they do have an adverse event, it goes up by 1.2%. So then if they have no adverse event, it would be 2%. If they do have an adverse event, it would be 3.2%. For CAUDIs, urinary tract infections, the underlying mortality of people that get a urinary catheter inserted is 7%. So this is a sicker population. They already have a 7% underlying mortality. Getting a CAUDI increases it by 50%, 3.6% more. So that goes up to 10.7% if they get a CAUTI. So they did this research and made these estimates. And you can see they put the confidence intervals quite large here. This is very tricky. This one is interesting too. Ventilator-associated pneumonia, they have a 30% death rate for being on a ventilator. This was increasing it by 14%, but you can see the confidence interval here actually included a negative number because this is very uncertain as to how much people actually are more likely to die if they have a ventilator-associated pneumonia. But you see the numbers here. These were based on reviewing the literature, not based on looking at charts. So we know that adverse events are highly correlated with inpatient deaths, but it's really tricky. So for example, this is what I put here, correlated but not caused. Say somebody died one day after a CAUTI diagnosis, they were already terminal. So they had a urinary tract infection one day before they died. This isn't what killed them, unless it was a bloodstream infection that was undiagnosed until it was too late. But in general, these kinds of things are not actually causing the death, but they're correlated with the death. And then there are things that outright kill somebody. You give somebody a 10 times intravenous opioid overdose, the decibel place gets moved by 1 point, and you give it to them, and they'll stop breathing and die. And unless somebody catches it immediately, they're going to die. I've seen that in actual reports. I saw one of those actually when I was at the Department of Veterans Affairs. This is another famous one, wrong route administration. Something that's supposed to be going to the bladder gets put into the blood, and it kills the person. Horrifying adverse events. Undetected post-op internal bleeding, so forth. Blood incompatibility. The practice where I had surgery, about 10 years later, I read in the Washington Post, they accidentally killed somebody by giving them a wrong blood type while they were in the hospital. Could have been me. I just got lucky because I had transfusions during my stay too. So some of these ones are in between. The previous slide I showed correlated but not caused, correlated and caused. And then there's a whole bunch of them that are in between. And then there's a lot of things to think about. Was the adverse event a known risk that the person consented to in the consent form? Was the adverse event preventable? A lot of people die from these hypoglycemic events in our data. This is basically the blood sugar being driven too low by insulin. But sometimes they may have been given the intended dose and somehow they had a strange metabolic reaction to the insulin and it killed them. And that may not be preventable. And then there are cases where maybe the adverse event wasn't preventable, but maybe the death was preventable. So for example, if somebody gets a drug that they've never had before and they have a severe allergic reaction to it, quick action by the staff might save their life. So maybe the adverse event wasn't preventable, but the death could be preventable. So it gets really, really complicated. I'm just going to go into one more study that we did. I don't want you to look at this in any detail. This is another time period where we showed the adverse events were going down from 2010 to 2019. This was published in the Journal of the American Medical Association. And these lines are basically rates from 2010 to 2019. And you can see that mostly all leaning to the left, leaning down left to right. So they're going down over time. And then this is basically similar results after risk adjustment with these lines on the right over here, a little red line being 1, everything to the left of that line being less than expected. So after risk adjustment, we were seeing less than expected adverse events as time went on. As I mentioned before, these are very correlated. This is a follow-up to the 2010 OIG study that I mentioned. This was based on a phone call I had with the OIG staff back in 2010 and got some numbers that were not actually published in the study. Their 12 deaths that I mentioned earlier were out of 29 deaths overall. So 12 out of 29 deaths overall were related to some extent to adverse events in that study of 838 patients. So this is what I was talking about before, like a hypoglycemic event. This is patients that had this event in 2016. When they had this event in our study, 34 out of 439 died, 7.7% death rate. Out of the 6,295 patients that also got those same kinds of drug, hypoglycemic drug, 240 died without the adverse event, 3.8%. So people that got the same kind of drug died at a 3.8% rate here. And then if they had the adverse event with the drug, they died at a 7.7% rate. Same thing here with heparin, which is an anticoagulant, 6% death rate just getting heparin in general, but no adverse event. If you have a heparin adverse event, the 25 out of 120, 20% die. And if you go over to the right side of the screen here, you can see almost everything is much more common. Death rate's much higher when the patient had the event, but not in every case. So it's fascinating, say for something like pressure ulcer, 3.9% with no pressure ulcer. If you get a pressure ulcer, your chance of dying is 12.5%. But that's a tricky thing, right? Because not everybody is prone to pressure ulcers. You're more likely to get a pressure ulcer if you're old and you're weak, you have all kind of metabolic problems. You may be very scrawny, your bones are right close to your skin. There's a lot of factors that can make you more likely to get a pressure ulcer. So it's not just the mere pressure ulcer. There could be other things causing or related to the death. But nonetheless, out of the overall population, it's quite a significant risk factor. But one thing that's also interesting here is if you look at something like here, the ventilator-associated pneumonia again, there's no difference. It's 20% with an adverse event, 26% without. So the pneumonia doesn't seem to cause the death. But in general, pneumonia is still bad for people. You can see people that had surgery and didn't have pneumonia afterwards in this group died at 1.2% death rate. But if they had pneumonia after surgery, they died 11% rate. Again, this is not risk adjusted. This is just the raw numbers. So maybe these people were much sicker to begin with, but nonetheless, they're highly correlated. This is another extrapolation about deaths being preceded by adverse events. This is a number that I came up with. This is not deaths caused by, about 280,000 deaths preceded by. So this would go with like 700,000 deaths. So it's 280 out of 700,000 is about 40%. So there's a lot of adverse events among the people that are dying in the hospital. So what do we know? So what we know, I think, is unsatisfying. We know that very many inpatient deaths are preceded by inpatient adverse events. But we don't know how many deaths are caused outright by the inpatient adverse events. The really conspicuous ones, like a 10-time opioid overdose or a drug reaction, or say bacteremia, some kind of serious bacteremia, bloodstream infection, sepsis that's hospital acquired in a patient that was healthy when they came in. There's some of these types of events that are really clearly caused, but there are very many deaths that are just preceded by adverse events that are not caused by them. So just go a little bit more with these couple of bullets. Just think that even those that would have died during the stay might have experienced some more good days without the inpatient adverse event. So it's not just the fact that the adverse event killed the person. It can shorten their life by maybe a week or two or something, which maybe isn't trivial. With the end of life, maybe every day is precious, especially if you're spending with family members or people coming to see you and so forth. So you can't just dismiss it if they were terminal. They had 2 weeks to live and they died a week sooner or something. You might think that's trivial compared to somebody that loses 50 years of life. And it is to some extent, but it's still not nothing. And you can see here, some of these people suffering these adverse events can be miserable, and they could die in a much more painful or unpleasant way due to having suffered the adverse event. And then one last bullet is, it's a horrible thing to mention, but or maybe not horrible, maybe it's a positive thing to mention, which is that there's a lot of people out there that suffered adverse events during their stays and didn't die. And the things that were done during that stay saved their life. So I'm in that group. I had a major surgery in 1999, and it was a life-saving surgery. It was a subtotal colectomy for ulcerative colitis, and I probably would have been dead within a few weeks. I was basically slowly bleeding to death and losing weight and dying, and I needed to get that surgery to save my life. Now, afterwards, I had a series of surgical site infections that took months to heal, but they did heal. And the only thing I'm left with is more scars on my belly than the average 61-year-old. But I've had 25 plus years of life. So it's a tricky thing to contemplate as you think about these adverse events. and the deaths associated with them. And that's the end of my presentation, Kevin. And thank you for listening, everybody. And I would be glad to take any questions or listen to your ideas, hear your comments.